approach to bone tumors. It is a teamwork. How to particular session we take imaging approach to bone tumors. It is a teamwork. How to diagnose, how do you manage, how do you follow up. It's a teamwork. First, of course, the clinician, he sees the patient, and then the radiologist sees, and whatever imaging method he adopts, he uses a particular diagnosis, and ultimately the pathologist. And today it is a molecular medicine that gives us the clues for bone tumors. What are the investigations? As usual, conventional. Today is digital radiography that is popular, ultrasonography, MDCT. Occasionally you can use dual energy CT, radionuclide scanning, MRI, MRA angiography if necessary, spectroscopy, PET-CT. See, in all these modalities, Mark Twain once said, for a man with a hammer in his hand, wanting to use it badly, everything in this world looks like a nail needing hammering. The moral of the story is, today, especially in the corporate sector, there are high-tech equipments, costly equipments. And earlier what we used to do by plain radiography diagnosis, today they forget about conventional radiography and they straight away jump to MRI and CT. Irrespective of the cost, they follow this because they have got equipment in their hand. They want to use it. That's the moral of the story. Now for this session we use only benign bone tumors and tumoral conditions. That is swellings which simulate tumors. And what is the conventional radiographic or radiological approach? There are certain principles. You see, in every madness there must be some methodology. Principles of radiological diagnosis of bone tumors in general, whether benign or malignant or tumoral conditions. First of all, age. Age, I always insist, it should be taken into consideration because, say, look at an X-ray of the skull. There are multiple lytic lesions. Don't diagnose as multiple myeloma. In a 5-year-old child, multiple myeloma does not occur. So age is very, very important. And then sex is not that important because there is a slight prevalence in males because they come often to the radiology department, often they approach the clinician. Single or multiple lesions is also important. When you see a lesion, think, could it be single? Not always you have to do a bone survey or nuclear scan, but think, is it possible that the patient has got another clinically silent lesion? And then type of bone involved. That is, there are 3 types of bones as we know. Cuboidal bones. Examples are corpus, tarsus, vertebrae. And flat bones, scapulae, iliac wings, even calvaria. And then cylindrical bones or tubular bones, all the femora, tibia, radius, ulna, even ribs. So the type of bone involved, because I am telling you this, because for example, take cuboidal bones or flat bones. Periosteal reaction is not often seen. Not that there is no periosteum in the flat bones or cuboidal bones, but it is closely incorporated. For any stimulus, whether infection, malignancy, or any other stimulus, trauma, periosteal reaction is not imminent. Whereas in tubular bones, particularly in children and growing adolescents, the periosteal reaction for any stimulus, trauma, infection, or inflammatory or any other causes, periosteal reaction is obvious. And then site of the lesion within the bone. Is it cortical? Is it periosteal? Is it spongiosal? And then is it diaphysis, metaphysis, or epiphysis? And then site of origin. Is it from cartilage? Is it from bone? Is it vascular? Lipomatous tissue? That also, beforehand, you should determine nature and extent of bone change, because some benign lesions could be very aggressive, breaking the cortex, producing the soft tissue swelling, pathological fractures. Transitional zone, that is, a normal bone and the abnormal bone. The zone between these two, is it wide? Is it narrow? Often in benign lesions, it is narrow, whereas in malignant lesions, it is wide. Aggressive nature, as I said earlier, Is it breaking the cortex, entering into the soft tissues? Matrix, that is the center of the lesion. Is it calcified, ossified, lipomatous, vascular? You have to determine in order to make a final diagnosis. And then periosteal reaction, as I told you earlier, if it is present, if it is linear, unilaminar, multilaminar, compact, spiculated, lace-like, all these are the types of periosteal reaction that would give an indication to the diagnosis of the tumor. And soft tissue involvement. Generally, the soft tissue is localized soft tissue involvement. Sometimes in the soft tissues, there may be calcification, ossification, or there may be lucency, which gives rise to the clue for a final diagnosis. All these parameters are important. I'll give you a few cases for a quiz. Say, take this. 23-year-old man comes with a painful finger. Index finger is painful. Night times is worse. What do you see on this radiograph? You look at the distal phalanx, especially on the other side, see a lucent area, a big lucent area, the central density. Of course, soft tissue is swollen, but you can't really identify. There are no soft tissue calcifications. So what is the diagnosis? We'll go through them again. Another 24-year-old female with painful finger. And then you could see a soft tissue swelling, multiple nodular type of ossifications and calcifications, and erosion of the phalanx with reactive sclerosis surrounding it. That indicates it must be chronic. Chronic of long-standing duration. Make your diagnosis. Another case, 30-year-old man with pain in the knee. AP and lateral views of both the one knee. And you see the large lytic defect in the metaphysio-epiphyseal area. Epiphysis, of course, is already fused. It doesn't go all the way to the articular margin. And central matrix, maybe there is calcification. It's not purely lucent, but there is some haziness at the center. Make your diagnosis. 18-year-old boy fell from a bicycle, and complaints of pain came to the department. You see a lesion, cortically oriented, lytic lesion, but it is surrounded by sclerosis. And there are some bubbles of sclerotic lesions, lucency with surrounding sclerosis. It is eccentric, cortically oriented. It doesn't go beyond. But incidentally, there is a linear fracture also. Frankly, what happens in these entities, the trauma brings the patient to the clinician. Not the lesion is not painful or anything. Make your diagnosis. 35-year-old with a painful heel. What do you see? Large, again a lucent area with central calcific density. A lucent area with clear-cut margins. Transition zone is clear-cut, telling that it must be benign. Make a diagnosis. 33-year-old with painful left hip. What is the lesion? It is mainly in the lesser trochanteric area, extending down and up into the neck. Lytic area surrounded by sclerosis. Transition zone at the femur, quite thin. There are some trabecular lesions. And then there is the lesser trochanter, there is a linear fracture also. That's how the patient came to the orthopedic surgeon and he asked for a plain film of the hip. Make a diagnosis. Again, we review. Please correct your diagnosis, whether right, wrong. Maybe have you given a differential diagnosis, because you should give one diagnosis because classical cases. There is no question of a differential. In discussion, you can discuss differential, but not in writing. Only one diagnosis. As we said, painful finger in 23-year-old. Male diagnosis is osteoid osteoma. Why is osteoid osteoma painful? And cortically oriented lucency, the dense sclerotic central bone. Classical example. Of course, we know it is benign because there is the transition zone is thin. 24-year-old female, painful finger, juxtacortical chondroma. You should diagnose it must be a chondroma. It's not an enchondroma. It's a chondroma, eccentric chondroma. That's why it's called juxtacortical or paraosteal chondroma also, some people call it. The nodular type of calcifications, the arc-like calcifications indicate it is a chondromatous lesion. And it is eccentric with a soft tissue swelling. And surrounding area of sclerosis, long-standing area. Correct? And this, I agree, is a little difficult. Could be a chondroblastoma, 30-year-old, not uncommon for chondroblastoma, but it is not involving the epiphyseal portion, mostly metaphyseal. Metaphyseal chondroblastoma also is seen. That's why I said it is difficult to diagnose. Calcifications are not real. There is some haziness indicating osteoid, but there are no calcifications. If there are calcifications, you could have thought of a chondroblastoma maybe. But this is a chondromyxoid fibroma. Could be an aneurysmal bone cyst. It is expanding. It has got a sclerotic border. At times, not in this particular case, the differential diagnosis is tough. But here, note the lytic area and the medial aspect of the metaphysis. No calcifications. Rarely in chondromyxoid fibroma also you may find calcification. But how do you differentiate between chondroblastoma? Only from the age. Most of the chondroblastoma are epiphyseal origin. In that age group, 22 years of age. Here is a 30-year-old man. All the epiphyses are fused. 18-year-old boy fell from a bike. The epiphyses are just fusing. And it is a classical example of non-ossifying fibroma. Of course, the lucent line indicating a fracture is obvious. The lytic area and the lateral cortex, cortically oriented, I said, is surrounded by sclerosis, that is healing. Healing occurs from the periphery to the center. Eventually, the whole thing may be dense and sclerotic. Trabeculae are sclerotic in the matrix, classical of a non-ossifying fibroma. No other differential diagnosis, frankly. 35-year-old, painful heel. What do you see? Markedly lucent area in the bone. It could be lytic area due to anything, say a giant cell tumor, but the site is not common. Aneurysmal bone cyst is not expanding. Simple cyst, there would not be any calcification. It is not uncommon in calcaneum. Large area of lucency indicates lipomatous tissue, the central calcification. That is a classical example of a lipoma, particularly in the calcaneum. Most of the lipomatous lesions do calcify because of the fat necrosis. It's not an osteoid osteoma because, why? Although the nidus is too big, but there is no sclerotic border. It's not cortically oriented. This is a little tough, but please keep it in mind that giant cell tumors not only occur in the former epiphyseal region, the former apophyseal lesions also. That's why in the greater trochanter giant cell tumor, here in the lesser trochanter, expanding internally into the shaft and into the neck, large lytic area, and lesser trochanter is also involved, and some bubbles. Ordinarily, you get classical soap bubbles because of the septae, but here it's a little aggressive, that's why you don't find too many soap bubbles. Now, the quiz is over. You have evaluated yourself. Let us see how much my lecture contributes to your making a right diagnosis, particularly in this particular session, benign tumors of the bone. They could be osseous, they could be cartilaginous, fibrous, vascular, fatty, or miscellaneous. That's why I said earlier, in the parameters, you have to know from tissue of origin. And then let us deal with osseous origin of the benign tumors. Osteoma, common, osteoid osteoma, osteoblastoma. In general, benign bone tumors will have a well-defined transitional zone between the normal and the abnormal. And sometimes it is called a rim or even a rind. Intact periosteal newborn formation. Periosteal newborn formation, rare, but if it is present, it is intact. It is not multilaminar or aggressive type of periosteal reaction. Pattern recognition, so-called Aunt Minnie type. For example, by the age you can tell, by the type of bone you can tell, by the location of the bone you can tell. Location of the bone, epiphysis, few tumors do occur. Metaphysis, lots of bone tumors occur. Skull, certain bone tumors occur. So you have to know the type of bone, etc. Osteoma, common, nasal sinuses, paranasal sinuses, in this case frontal. It can also occur anywhere. the flat bones, and the long bones. Osteoma is a compact bone. It sometimes is included in the spongiosal bone, frontal nasal sinuses. Sometimes it is so big in the frontal area, it may erode and produce a pneumoencephalocele. Some of them are ivory dense. For example, in a long tubular bone, a flat type of osteoma, a femoral shaft. In this particular case, is Gardner syndrome, where you can get multiple osteomata, the mandible and long bones, in the sphenoid sinus, and polyposis in the colon. Bone island. How can you differentiate between osteoma and bone island? Generally, osteomas produces swelling clinically and radiologically a tumor, whereas here they don't have any clinical significance. There is no swelling clinically, and these are not out of the bone. It is inside the spongiosa of the bone. Insular compacta. Compact bone is island, insulized in the spongiosa bone. Sometimes they are big, large, giant type of bone island. And scintigraphy in a growing bone island, scintigraphy may be positive. That doesn't mean it is a tumor, growing tumor. Then we come to the entity called Osteoid Osteoma. In 1935, Jaffe has described it. It could be, by location, it could be intracortical, subperiosteal, spongiosal, only in which case we have to differentiate from bone island, but spongiosal osteomas are not dense. Anyway, we'll come to that. Subarticular or intracapsular, simulating arthritis clinically. We'll take up osteoid osteoma. In 1935, Jaffe has described this for the first time. And location-wise, it could be intracortical, it could be subperiosteal, spongiosal. If it is spongiosal bone, remember I said earlier, in the spongiosal bone, if it occurs density, it is osteoid bone island, but then it's not dense. And then subarticular, which can be intracapsular, may simulate clinically arthritis. Look at this picture. Young boy, the epiphyses are not fused, and there is expansion of the bone of the phalanx, marked sclerosis, and a central density, all indicating osteoid osteoma. Why not osteomyelitis? There is no periosteal reaction at all. Spongiosal. You can't think of a lipoma, and it's not dense to think of a bone island. Again, osteoid osteoma. There is a nice sclerotic rim. It is painful. Occasionally, insignificant cysts can occur in long bones or flat bones. But here, if you look carefully, the metaphysis is widened, because most of the osteoid osteomas are hypervascular. Of course, this is osteoid osteoma. This is not much of a nidus, but if you take CT, there may be some bone debris. Again, in the midshaft of the ulna, osteoid osteoma producing diffuse sclerosis. Nidus may not be identified in this particular case, in which case you have to do a CT or isotope scanning or even MRI. The one in the lower side, on your right hand side, subarticular on the left hip, note the relative osteoporosis, widening of the joint space. It produces synovitis, almost looking like as if it is a synovitis. And then if you look at the subarticular area, the small sclerotic bone island, indicating osteoid osteoma. Again, MRI and CT would help to confirm the diagnosis. We come to osteoblastoma. Osteoblastoma is nothing but a giant osteoid osteoma. Generally, the nidus should be more than 2 centimeters. If it is less than, call it osteoid osteoma. Again, the age is more than 30 years. Males and females 2:1. 34% of them involve spine. Nidus, as I said earlier, more than 2 centimeters. Cortical, again, as I described in osteoid osteoma, cortical, spongiosal, subarticular. This also could be cortical, medullary, or periosteal. About the age, once again I have to tell you, it is not necessarily more than 30 years. We have seen several cases less than 30 years also. To the film, that is most important. This is, look at the epiphyses are not fused, so it is obviously less than 20 years. And then in the diaphyseal area, more in the metaphyseal area, large lucent area, more than 2 centimeters. And look at, maybe central calcifications are seen but not obvious. And look at the periosteal reaction, triangular, so-called Codman's triangle, almost triangular, but the entire triangle is filled up with new bone. That's the periosteal reaction, osteoid osteoma. Surrounding the lesion is sclerosis. Osteoblastoma in the rib again, in a flat bone. Note the large lucency, more than 2 centimeters, and central calcific nidus. And morphologically, you can describe osteoblastoma as ABC, simulating aneurysmal bone cyst, expanding, elytic, or fibrous dysplasia type, particularly in the vertebra, crazy type of new bone formation, osteoid formation. And then osteoma type, it may simulate, unless you measure the nidus, you may think it is only osteoid osteoma. And osteosarcoma type is aggressive, is what is called malignant osteoblastoma, aggressive with the periosteal new bone, soft tissue swelling, break in the cortex. A film of the cervical spine, pain in the neck, osteoblastoma of C2. Why can't it be aneurysmal bone cyst? Sometimes, ladies and gentlemen, osteoblastoma and aneurysmal bone cyst coexist. That's why it's large, lucent area. But some new bone formation is noted, not the residual trabeculae that you see in aneurysmal bone cyst. Some new bone formation. That's why it is osteoblastoma C2, spinous process. And then we have finished benign bone tumors of osseous origin. We want to go to the benign tumors of cartilaginous origin. Chondroma, most common, particularly in the bones of the hands and feet. Osteochondroma, exostosis, multiple osteochondromata, multiple exostosis, paraosteal chondroma, and then chondroblastoma, and then chondromyxoid fibroma. These are, chondromyxoid fibroma is more or less a fibrous tumor, but since there is a cartilaginous component also, we included this in the cartilaginous origin. Chondroma, classical lucency with surrounding sclerosis. Sometimes you may see punctate type of calcification. Multiple chondromatas also occur. In fact, if you look at the fifth metacarpal on your left hand side picture, there is a marked sclerosis and some calcification. There is a healing and chondroma. How does it heal? Mainly by incidental fracture or trauma. Of course, spontaneous healing they call it, but it must be some trauma stimulated new bone production. One on your right hand again, chondroma with a pathological fracture, lobulated lucency with calcific densities, classical of chondroma. Here, juxtacortical chondroma. I showed you that the film on your right side earlier. Juxtacortical, soft tissue swelling, cartilaginous calcifications. And here on your left hand side, the lower end of the femur, look at the cortex, juxtacortical, multiple calcific densities, and then hook-like projection of the bone with a radiolucency. Whenever you see that hook-like, think of chondromatous origin. Of course, hook-like or overhanging margin can also be seen in gout, but this is a linear type of lesion, cortically oriented. Think of a chondromatous lesion, and this is a juxtacortical chondroma. Multiple chondromata. Sometimes these can be associated with hemangiomata also. Some of these are enchondromatas, some of these are para-osteal or juxtacortical chondromatas. There is one entity called Ollier's dyschondroplasia. Some people enchondromata, they call it Ollier's disease, but there is a specific entity called Ollier's dyschondroplasia. Look at the long bones. These are enchondromata, but look at this extension into the periphery, into the cortex, and linear nature. The columns of cartilage are not calcified, that's why linear lucencies are seen. This is Ollier's dyschondroplasia. Exostosis, pedunculated osteochondroma. Some of them are sessile, some of them are pedunculated. Pedunculated can produce a fracture with a minor trauma. It is extending out into the soft tissues. Look at the cortex outlining the lesion. This is what we call sessile osteochondroma, arising from the lower end of the tibia. It is slow growing, that's why it is eroding the fibula, and not only eroding, producing reactive new bone. So chronic. Another benign osteochondroma arising from the humerus itself, multiple calcifications. The cortex could be outlined. Multiple osteochondromata is a familial, autosomal dominant, multiple exostosis you can call it, derangement of the epiphyseal cartilage, it's displaced, retarded long bone growth because of this, and secondary chondrosarcoma is fairly common. In the sense, 10 to 15% of the time you can get chondrosarcoma in one of these lesions. Radiograph of the pelvis, look at the variety of osteochondromata arising from the pelvis, from the necks of the femur, from the metaphyseal portion, from the pubic bones, and then in the forearm producing a Madelung type of deformity, short, ulnar because of the osteochondroma. What are the complications in these multiple osteochondromatas? Exostotic bursatica, it's a big name. Large bursa can be formed under the exostosis. Pressure on nerves, adjacent nerves, or even vessels, occlusion of the vessels we have seen. Deformities, you have seen a Madelung deformity. Fractures, with a minor trauma, and malignancy is a major complication. Again, multiple exostosis. Look at that chondroma in the fifth metacarpal, marked calcifications. It is a multiple, look at the, again a Madelung deformity, but that particular mass and chondroma is producing massive calcifications and potential for malignancy. And then we will know when do you think of malignancy in a exostosis or a osteochondroma. One, clinically if it is painful, clinically if it is a big mass, and radiologically if the calcifications are dispersed, and radiologically even ultrasound wise if there is a thick cartilage cap which is disrupted often. This is again an osteochondroma or exostosis arising from the epiphyseal portion. This is what is called Travers syndrome. Travers, T-R-E-V-O-R-S. DP radiograph of the right ankle of a child age showing a lesion, the medial dome of the talus and epiphyseal part of the fibula. Generally it is unilateral. Again, osteochondroma-like growth from one side of the epiphysis at the tibia articular articulation. This is also called dysplasia epiphysealis hemimelica, DEH, dysplasia epiphysealis hemimelica, or Travers disease, T-R-E-V-O-R apostrophe disease. Again, Travers, another at the ankle. Now we come to the entity called Chondroblastoma. 1% of bone tumors, you may get Chondroblastoma. Benign, again Jaffe and Lichtenstein have described this in 1942. Second and third decades common. Frankly, second decade is more common, may extend to third decade. Long bones, more common than flat bones. Epiphyseal, or it could be apophyseal, well-defined lytic area. This I showed you the film earlier. Metaphyseal. Calcifications occur in 30% of the cases. Periosteal reaction may be present, particularly when it is metaphyseal. Epiphyseal lesions, there is no periosteal reaction. And occasionally, even in benign chondroblastomata, you may get pulmonary